Well, I see it's 12 o'clock, and I'm excited to invite everyone to today's session of the HTRC webinar series. I'm Robert Stiles. I'm the Policy and Outreach Director with the HTRC. Wanted to introduce Rochelle Marting, who works with us on policy issues as well, and has been leading us in this excellent series looking at various components of telehealth, looking at services, requirements are, and a lot of emphasis on billing and payment, because as we know, as much as we may want to do something or find it beneficial for our patients, if we can't get paid for it and cover our costs, then we can't really do it. I say that as a former CEO. Want to do a lot of things, but if you can't afford to do them, then you can't do them. So hand off to Rochelle, and I appreciate having everyone here today.
All right, thanks, Robert. So what we're going to talk about in today's session really builds on the topics that we've talked about in previous weeks and in previous months, and will be focused on true traditional telehealth services, the way that term is defined by Medicare, and how that affects hospitals and critical access hospitals, and some of the arrangements that you have, both as originating sites, as distant sites, as having healthcare professionals within your organization that may be providing and billing for telehealth services as professional distant site telehealth services. We'll talk about some of the changes that have happened in the last year and a half or so. And as we are starting to kind of unwind some of the COVID flexibilities, what that may look like for you, although as of today, a lot of that's going to be unknown, but we'll talk about some things to keep an eye out for as well. When I was preparing for this presentation, I saw this cool fact on one of the CMS pages that I think we hear, we know, and we see how much telehealth has grown in the last year and a half since the COVID public health emergency was declared. But this to me really drove home to what extent. So prior to the public health emergency at the federal level, Medicare patients were only receiving about 14,000 telehealth services nationwide per week. And I was kind of shocked with what a low number that was. Now, once the public health emergency was declared, and remember in March, it was probably the second, third week of March, was when it really hit hard. Everyone went home almost overnight. And telehealth then really exploded almost overnight. So between March and July, really in the thick of COVID, I don't want to say the worst, but maybe the peak of the COVID public health emergency, more than 10 million Medicare beneficiaries received telehealth services during that time. So if I've done my math correctly, I think that came down to about 500,000 per week, compared to the 14,000 per week that were happening prior to COVID. So it's just fascinating to me. When we say it's grown exponentially, it truly has grown exponentially since the public health emergency. Now, this is kind of an interesting time. I've thought of this group. Earlier this week, I was taking my kids to an event. It was an outdoor event, something that, 6 months ago, a year ago, everyone would have very strict 6-foot social distancing. We'd all have our masks on outside. And as we were kind of approaching, my kids kind of had this panic. They're like, oh my gosh, Mom, our masks, no one's wearing their mask. What do we do? And they're trying to figure out what the rules are right now, because they still wear masks when we go to our indoor events, but if we're outdoor, they're not wearing them. And it's just kind of this weird time. And they're so used to doing it that they don't know socially what the rules are right now. And I could totally sympathize with them, because in the context of telehealth and billing and what the rules are on a day-to-day basis, we're almost back in the position where we were a year ago, where things are happening so quickly, just in the reverse of what they happened last year. So there are some things that have happened just in the last few weeks that I want everyone to be aware of, things that are going to be happening in the next few weeks or next few months that will have a significant impact on our telehealth services, how we deliver them, whether and how we can bill and be paid for them. So the last month or two, we are starting to see states' emergency declarations that were declared by the governor of each state expire or be rescinded. And the impact of that is that a lot of the flexibilities at the state level that deal with licensure, that deal with expanded access to telehealth services, Medicaid coverage of different telehealth services, may start to unwind or revert, or we may start to see legislation at the state level making some of those temporary flexibilities permanent changes in telehealth within the states. So Oklahoma, we may have talked about this last time. I think the state declaration, emergency declaration, expired just a few days prior to our last session. So that was effective May 5th. The benefit or maybe advantage that Oklahoma had was from their Medicaid perspective. They already had pretty broad coverage for telehealth even prior to COVID. So I think they're in a little bit better position as things start to revert back to pre-COVID rules than maybe some of the other states that didn't have as robust telehealth coverage will be in. And Kansas, we are among those. What is today? 16th, the 17th? 17th, 2 days ago, our state's emergency declaration expired on June 15th. And so now we have a lot of executive orders that had been introduced relating to COVID, relating to telehealth, that were only effective for the duration of the state's emergency status. And so we have those flexibilities that now that the state emergency has gone away, may no longer be in place. Some of them were agency announcements and agencies' policies that were tied to executive orders related to the emergency declaration. So we're going to have a lot of questions on things like licensing and scope of practice and the type of medications that can be prescribed during a telehealth session or cannot be prescribed during a telehealth session, that I think we're going to see more guidance coming out in the very near future, as well as potentially legislation to change telehealth rules to possibly make some of these flexibilities permanent changes in our telehealth coverage and services. Also within the last week, we've had a federal bill introduced in Congress. It's bipartisan, so we had 2 Republicans, 2 Democrats introduce this bill. Kansas's Jerry Moran is one of those, called the Protecting Rural Telehealth Access Act. And this act, at this time, it's in the very early stages of federal bill. So I don't expect to see anything happen very quickly on this. But what this act would do is create payment parity for audio only, meaning telephone appointments. So what we've seen in the last year, around March of last year, Medicare began paying for telephone only visits as telehealth services. And that was significant because the federal statute requires that to be a telehealth services, there has to be audio visual communication. So kind of like we're having now, it's you can hear me, you can see me, it's real-time conversation, not an email that's kind of a communication, you wait, you get a response. And so when that was added as a temporary flexibility in March of last year, providers were able then to have phone calls with patients in exchange or in replacing an in-person visit. They weren't paid very well though. And in May of last year, Medicare increased the payment for these audio only, these phone call visits to mirror office visit services, office visit codes that had similar time components to the phone call visits, and they were at the same payment rate then. So what this bill would do is make that a permanent change, since once the public health emergency ends, there is an underlying federal statute that telehealth is only audio visual, and the Department of Health and Human Services and Medicare will not have the ability, the authority to allow us to have phone visits unless there is literally an act of Congress to change that. So be aware that that is something that we may see changed at the federal level on a permanent basis. So this may be an act you want to follow. And actually, if you go to the congressional website, you can subscribe to different bills, so you get updates if there are changes, if it progresses, if it's voted on, and you can follow that bill through Congress. Another change that would happen if this bill were to be passed is that it would permanently waive originating site geographic restrictions. There are a number of telehealth bills at the federal level in Congress right now that would do this. So what we know with the federal public health emergency is that if it ends sometime in 2021, many of the flexibilities like originating site restrictions would continue. The flexibilities would continue through the end of the calendar year in which the public health emergency ends. Another thing we know, although it's not binding, is that the Department of Health and Human Services has advised governors that Health and Human Services intends to give everyone 60 days notice before the public health emergency ends, to allow an opportunity to have a plan to wind things down and revert back to non-emergency statuses within the states. So what I anticipate that if the public health emergency at a federal level ends sometime this year, we've got enough bills in Congress addressing the originating site restrictions for telehealth services. I think it's only a matter of time before one of those passes. And what that means is the originating site restrictions mean that the patient has to be in a rural area. Right now, that's one of the requirements for telehealth services. So if the public health emergency were to go away and we revert to pre-COVID rules, in the Kansas City metro area, in the St. Louis metro area, Oklahoma City, you all would not be able to deliver telehealth within your metropolitan areas unless and until, I guess, let me back up, for Medicare recipients, unless there is an act of Congress to change that originating site restriction. And like I said, I've seen numerous congressional bills interested in changing that. So I think it will happen. The question from my perspective is, will it happen fast enough so that there's no gap and there's a continuity in the way we're delivering telehealth? Or will the public health emergency end? We go back to pre-COVID rules that restrict us to providing telehealth to Medicare recipients, to patients who are in rural areas. And then we have the act of Congress that lets us go back to the flexibilities we're currently seeing. And so there may be some back and forth if Congress doesn't move fast enough. This act would also permanently allow rural health clinics and FQHCs to act as the distant site providers of telehealth services. That's a flexibility we have right now during COVID that was not available to RHCs and FQHCs prior to the public health emergency. This is interesting too. It would remove restrictions on store and forward technology. Right now, that's only available as a telehealth communication system in certain demonstration projects in Alaska and Hawaii. And if this act were passed, it would remove that restriction, which means it would allow the use of store and forward technologies to be a type of communication that you can provide telehealth through, which is different than the live, two-way, real-time communications like what we're doing right now for a telehealth service. And important for some of you on this call, it would also allow critical access hospitals to directly bill for telehealth services. So we'll keep an eye on that, because certainly among this relatively new bill and others that are out there, it looks like there are going to be some federal changes to telehealth on the horizon in the relatively near future. So now I want to go through some of the COVID telehealth flexibilities that apply to hospitals and I don't know if the word regular hospitals, IPPS hospitals, right? And critical access hospitals with respect to telehealth services. So right now, the federal public health emergency from the Department of Health and Human Services is still in effect. As far as I know, there's not been any communication of a plan to rescind or to allow that to expire in the next 60 days. So as of right now, I'm guessing, I kind of anticipate that in July 19th, the next expiration date, it seems like it is likely to be renewed for another 60 or 90-day period. It's typically a 90-day period. Might be surprised on what happens in the next 3 or 4 weeks, as we know things can happen quickly. All signs point to that possibly likely renewing at the federal level. And during the public health emergency, so long as that is in effect, Medicare allows us to provide telehealth to patients who are at home. And outside of the public health emergency, the patient's home is not an eligible originating site. That's another flexibility that I've seen built into a lot of the bills that are being introduced in Congress at a federal level to remove not only the geographic restriction requiring telehealth be delivered to someone in a rural area, but also removing the restrictions that prior to COVID did not allow us to deliver telehealth in someone's home. And gosh, as the emergency has run its course in the last year and a half or so, the patient's home seems like a really good place to deliver telehealth services, to avoid exposure, to increase access in a face-to-face setting to individuals who really need that in-person, face-to-face type service versus a telehealth, something that could be managed in a telehealth environment. During the federal public health emergency, Medicare will pay for telehealth regardless of the state where the provider is located. So let me clarify what I mean by that just a little bit. One of the earliest telehealth flexibilities that Medicare issued was a payment rule under the Medicare program that says providers of telehealth have to be licensed in the state where the patient is located. And that's pretty consistent with state practice of medicine and scope of practice licensing rules. But Medicare, from a payment perspective only, removed that requirement. So with those of us on the call, if we had a physician in Kansas who is not licensed in Oklahoma, but delivered a telehealth service to a patient in Oklahoma, from a Medicare payment perspective, Medicare would allow that service to be paid that prior to COVID would not have been allowed. But that is a payment rule only. It did not address whether or not that service could have been the unauthorized practice of medicine under Oklahoma's licensing laws. So it addressed it from a payment perspective, but we still had some legal challenges to make that type of service arrangement happen. Another flexibility that we've seen during the public health emergency with respect to telehealth, particularly relevant to hospitals and critical access hospitals, is that when services require supervision of a physician, when the service is delivered by telehealth, that supervision can be accomplished through audio-visual communication. So if we were on a Zoom telehealth session and I have a physician supervising that service, that supervision could be accomplished by immediate availability to join the telehealth session, right? We just send Dr. Smith a link, Dr. Smith joins our meeting and can now help with that telehealth service, as opposed to in-person only, because if we're delivering a service via telehealth, there is no in-person service and no way to provide supervision in an in-person manner. So a couple of other provisions that are particularly relevant to hospitals and critical access hospitals are the professionals within your organization, the physicians, the nurse practitioners, the physician assistants, residents, can provide a telehealth service from their home. And that previously was not permitted. And one of the reasons it's not permitted is that when a professional provides a service on the claim form, if you go back to our sessions where we've broke down the claim form kind of field by field, at the very bottom of the CMS 1500 claim form, there's a field that identifies where the service was provided. So if that is in a hospital outpatient department, if that is in a physician clinic, the name and the address of the clinic or the outpatient department is what goes in that field. And that's typically where a telehealth service would have been rendered from. But now, during the public health emergency, to reduce exposure, to increase access to telehealth services, Medicare allowed the professionals to deliver those services from home without requiring that location, the home address, to be registered as a service location in the provider's enrollment with Medicare. So when we report the hospital outpatient department address or the clinic address on the claim form, that tells Medicare not only where the service was provided, but there's also a matching process that happens. They'll look at Rochelle Marting's enrollment information with Medicare. What are the sites of service I have enrolled? The clinic setting, the hospital outpatient setting, et cetera. And then they'll look at the address on the claim form where I provided the service. And if that location doesn't match with the location I've enrolled, Medicare wouldn't pay for it. So during the public health emergency, when providers were delivering services from home or a hotel, if they're traveling around to help out with the crisis, or other service locations, they can do that without having to register the home or other site on their CMS enrollment form. They would simply use the place of service, use the service location that they would have used if this were an in-person service. When the public health emergency goes away, I anticipate that flexibility will go away. Meaning if we have providers who are wanting to provide telehealth services from home on a regular basis, they will have to register their home as a practice location on their CMS 855 registration, provider enrollment paperwork. Right now, under the public health emergency, we don't require, I mentioned that the providers don't currently have to enroll their home as a provider location. However, there continues to be a restriction now. It in all likelihood is going to continue being a restriction after COVID, that the professional cannot be physically located outside the United States when providing a telehealth service. That is in a federal statute. So I don't anticipate that is going to change when our COVID flexibilities go back to quote unquote normal, because that actually wasn't, there was no flexibility for that during the COVID public health emergency either. So it's nice we have some options on where professionals are located to be able to see our patients, but they can't go to Turks and Caicos and provide telehealth from there if they're outside the United States. For the 2021 physician fee schedule for Medicare, and this applies for any professional service provided via telehealth, that rule clarified that telehealth can be performed incident to the professional services of a physician. What that means, if you were in a face-to-face in-person setting and you had a nurse do a blood pressure check, or if you had a nurse do an evaluation for a patient who's on anticoagulants and talk about, if there's been any bleeding or any other issues, something that would be like a nurse visit in an in-person setting. Medicare says we can also do that via telehealth, and you can do it incident to the physician's order or plan of care. When we provide a service incident to, there's a requirement that there be direct supervision. And in person, direct supervision means the provider is physically located in the office suite and immediately available to come in and help and provide services if needed. Well, that doesn't really apply to a nurse visit provided via telehealth. And so that direct supervision can be accomplished through virtual presence, the ability to join that telehealth session and provide assistance if needed. For hospitals that are using residents to help provide services, we have some COVID telehealth flexibilities that apply to that as well. One of those is that the requirement that you have a teaching physician present and provide key portions of the service in order to bill for that service. The physician presence requirement can be met for a resident telehealth visit by virtual means as well. So they can join the telehealth session, and that is sufficient presence, where A true in-person visit requires the teaching physician to actually be physically there in the room and part of a key portion of the service. That's going to be, that flexibility will be continued through the end of the public health emergency. But the way that was worded in the physician fee schedule is that this is not a flexibility that would continue through the end of the calendar year in which the public health emergency ends. So if you are using residents, if they are doing telehealth services, that's something we want to keep an eye out for when the federal public health emergency ends, because that will immediately mean the teaching physicians have to have in-person presence during an in-person visit, and that flexibility will go away. Medicare also said for that virtual presence, it has to be audio-visual, two-way, real-time in order to meet the requirement of a teaching physician's presence during a service provided by a resident. For purposes of that rule, an audio-only presence or ability to help with the visit is not sufficient. That would not allow us to bill for the service under the teaching physician's name and number. We still have to have the teaching physician participate in the visit. And the language in the Medicare manual for this is a key portion of the evaluation and management service, whatever the physician determines is a key portion, the history, the exam involved in the medical decision-making. So the teaching physician's availability only without actual participation is not sufficient. And of course, one of the challenges we have then when you're using residents and teaching physicians is documentation of that virtual presence, of the teaching physician's participation in the visit. Now, this first bullet describes something that's in effect outside of the COVID public health emergency. There's something called a primary care exception for the teaching physician presence requirement. And that primary care exception applies to certain primary care residencies that allow the resident to provide lower level evaluation and management services, so level 1 through 3 on a normal basis in primary care settings with general supervision as opposed to direct supervision of the teaching physician and teaching physician presence during the service. During the public health emergency, there was an interim final rule. I think this was the final rule in May of last year that expanded the existing and the permanent primary care exception that would allow residents in a primary care residency to deliver all levels of primary care services, so levels 1 through 5, and added that they could also do transitional care management. They could also do online digital evaluation and management services, communication technology-based services, and remote evaluation of images as part of that expanded flexibility. And that will go away when the federal public health emergency ends as well, unless we have an act of Congress to change that. Actually, that may be in the regulations. So unless we have Department of Health and Human Services change their rules. We have, relevant to hospital services during the public health emergency, broader flexibilities in the way we use verbal orders, and some relaxed requirements on medical staff credentialing and appointment rules. So if we have two facilities that sort of have a written agreement with one another, one is an originating site, one is a distant site provider of telehealth services, these regulations dictate certain content requirements and expectations of the written agreement between those two facilities and how the distant site providers are credentialed and appointed and how these telehealth services are rendered. So this is just so you have a copy of what this regulation looks like at 42 CFR 482.12. And this is just a condition of participation that outlines that there has to be a written agreement available. So let me see if I can. Oh, I think I can. What's that look like? There we go. Look at that. I've never done the annotations on here before. Outlines that a written agreement is possible and certain content requirements. And the waiver just relaxed those those specific details of the written agreement, so that if we were, March of last year, kind of overnight, entering into these arrangements for the provision of telehealth services, we didn't dot our I's and cross our T's on the written agreement. Medicare said for the duration of the public health emergency, that's okay. We'll give you some flexibility there. And this is just, last one was paragraph 8. This is paragraph 9 of the same regulation, and it essentially lays out some of the same things. So it gives us some flexibility on the written agreement between the distant site, the originating site facility, and some of the specific terms that need to be in those arrangements, only for the duration of the public health emergency. For critical access hospitals, one of our flexibilities right now is that the critical access hospital physician be present and available for direction and supervision of the services. That requirement is waived or relaxed to an extent, and right now allows the physician to be available through radio or telephone communication, other electronic communications, to assist with medical emergencies, where prior to the COVID emergency, there had to be a prompt availability to be on site to provide in-person direction and supervision of services. One of the big flexibilities, and almost in my mind, a little bit confusing in some ways, initiatives for hospitals, especially during the height of the pandemic, was this concept of hospitals operating without walls that gave hospitals and other types of healthcare facilities, both traditional IPPS hospitals and critical access hospitals, the ability to create alternate care sites to see patients as departments of the hospital. This could have been a white tent set up in the parking lot to screen and test patients as they come through, or to help see patients. And that tent, that part of the hospital without any walls, that alternate care site, could be considered a department of the hospital for billing and for licensing purposes. And Medicare said, if you are creating these temporary expansion sites, the tent, converting a gym to a healthcare setting, changing non-patient care areas like a cafeteria into a patient care setting, then several flexibilities would happen. Number one, there is a commitment not to survey those temporary expansion sites during the public health emergency for compliance with all of the typical patient care area requirements. It also allowed professionals to bill for their services at a temporary expansion site with a place of service, depending on whether the classification of the patient at that location was an inpatient or an outpatient. So that, in my mind, makes sense. We certainly saw that on the news a lot, the tents or the alternate care sites. But then Medicare expanded this concept of operating without walls a little bit further, in a way that for telehealth services for hospitals, I think got a little bit confusing. And Medicare would allow a patient's home to be considered an outpatient department of the hospital. And the significance of that is we could deliver services to a patient in their home and bill as though it were an outpatient department of the hospital, which means we as the hospitals were allowed to bill facility charges for those services. But we had to distinguish whether those services were telehealth or whether those services were outpatient department clinic visits. And I'm going to walk through a couple of scenarios that kind of illustrate the very fine distinctions between those two billing structures. When we provide a service as a hospital to a patient in his or her home, and the patient is registered as an outpatient of the hospital, it's possible that we could bill either an originating site fee, as if the patient were located in our facility and receiving a telehealth service from a distant site provider. And that originating site fee is designed to compensate for overhead expenses, to room the patient and to present the patient for the telehealth service. And in certain situations, hospitals then could bill for an originating site fee, where normally, if the patient's at home, there is no originating site fee for that service because there is no administrative overhead for that. And generally, institutional providers like hospitals and critical access hospitals are not billing for the distant site services because those are professional services that are billed by the physician or the nurse practitioner. In a roundabout way, the hospitals may be billing for that when they employ the physicians or the providers have assigned their right to bill to the hospital, but it's still a professional bill, not a hospital bill. Both IPPS hospitals and critical access hospitals can serve as originating sites. So if we have a critical access hospital and an IPPS hospital that are working together to provide telehealth services to the critical access hospital, the CAH can serve as an originating site and can bill originating site fees when the patient's located in those facilities. What this flexibility did was say if the patient's not actually in the brick and mortar walls of the hospital, but is at home, and we are treating the patient's home as a provider-based outpatient department of our brick and mortar campus, then we could still potentially bill an originating site fee. So one of the Medicare FAQs that I think was helpful on that subject: should hospitals submit a bill, a type of bill 12, for telehealth originating site fees during an inpatient stay? And Medicare answered that yes, you can submit a bill to receive a fee, receive payment as an originating site on top of your normal prospective payment system, DRG, or other payment methodology, and you could receive separate payment for that originating site fee. So now I want to go through a couple of scenarios to illustrate this concept of the patient's home being an outpatient department of the hospital, and some nuances to that and how it works from a billing perspective. So in this first scenario, we have a distant site provider. Here's my provider, providing a telehealth service to a patient who is physically situated in his or her home. Okay, there's our patient at home. The patient is registered as an outpatient department of the hospital. When that telehealth service is provided in that situation, the hospital bills an originating site fee for the telehealth service. Even though the patient isn't located in a healthcare setting, because they are registered as an outpatient, the hospital is able to bill the originating site fee. There's another code that's going to become important in a few of these scenarios, a HCPCS code G0463 that describes outpatient clinic visits. This is not an outpatient clinic visit. This is truly a telehealth service, and that's why we're billing an originating site fee. But let's look at this from a little bit different perspective. Here we have a provider who's delivering a service to a registered outpatient, but instead of the provider being at the healthcare facility at the hospital, the provider is at his or her home, because we can do that during the public health emergency and bill it as if the provider were physically located in the healthcare facility. This is also a telehealth service. It is basically the exact same situation as scenario one, because during the public health emergency, we would bill the place of service, not the service location, not as the provider's home, but we would bill what the location would have been if this were an in-person visit. And that's the normal practice location, the hospital, the clinic, wherever the physician would have provided that service from. So it is not a hospital clinic outpatient visit, and you would still bill the originating site fee only, the 3014. Okay, so let's change this a little bit. Now we've got a provider who is located, they use the term within the hospital when a service is provided to a patient. We have a patient who is located at home, and if the patient is registered as an outpatient of the hospital, and the hospital is treating the patient's home as a provider-based outpatient department of the hospital, then from a billing perspective, the patient's not actually at home. The patient is within the same hospital as the provider. And for billing purposes, then, if they were both within the same provider-based outpatient department of the hospital doing an in-person service, that's not telehealth. That is a hospital outpatient clinic visit. Very, very fine distinction there on the difference between telehealth and a service provided remotely. That is the language that Medicare uses. So this is not considered a telehealth service during the public health emergency. Okay, so let's look at another variation of that. We have a patient and a provider are both located, quote, within the hospital. But let's say they're not actually in the same room as one another. The provider is delivering this service from a different room, or maybe through like a plexiglass window or other service. So they can still see one another, they can hear one another, but they are not physically situated in person in the same exam room. And so the service is separated by some kind of wall or partition. So Medicare's instruction for those services is to bill as though it were a truly in-person visit where the provider and the patient are both within the hospital and physically situated in the same room, even though technically they're not. Okay, so the last thing that I want to go over are a couple of service-specific rules for telehealth services involving hospital care, and so the rules that came out in the 2021 physician fee schedule. So for hospitals, we have not always, for several years prior to the COVID public health emergency, we've been able to bill certain hospital visits as telehealth services. We've been able to bill hospital observation and discharge services on the same day admission and discharge. We've been able to bill subsequent hospital visit services via telehealth. So the 2021 physician fee schedule will continue to allow us to report same-day admission and discharge services when provided via telehealth through the end of the calendar year when the public health emergency ends. So as of right now, that looks like it may be December 31st of 2021. I'll put an asterisk on that though, because in about a month, we will see a proposed 2022 physician fee schedule. And now that we have a whole additional year of data on provision of telehealth, this is something that could become a permanent telehealth service, not just temporary. And the same with subsequent observation care services, that right now we have a limit to those being provided once every 3 days on a temporary basis. It's possible that we see that limit reduced or eliminated entirely now that we are using telehealth much more frequently for hospital inpatient care. And depending on what outcomes and data show, this actually was considered in the 2021 fee schedule for that frequency limit to be removed, and Medicare decided not to. But it's been a whole additional 12 months now, so I'll be looking for that in the proposed rule here in the next probably 4 to 5 weeks to see what we might anticipate happen with respect to those services in 2022. All right, so I'll pause there if you've got any questions on some of the flexibilities for hospitals and critical access hospitals for traditional telehealth services. And also mention that if you think of questions or things that you don't want to ask to the group during the live session, you're always welcome to reach out through the HTRC email address and ask those questions, and we can address those by email later. And I'd also encourage you, and this session was really focused on traditional telehealth services, but over the next couple of months, we're going to be doing a deeper dive into kind of quasi telehealth services, things like care management, chronic care management, transitional care management, virtual check-ins, and something that's been really big for hospitals and critical access hospitals in the last couple of years, remote patient monitoring. So they're not truly telehealth services the way that term is defined by Medicare, but they are services that are provided other than in a face-to-face manner that could be very beneficial for your organization. So if those are of interest to you, I encourage you to look out for those dates in future sessions.
Rochelle, I don't see that we have any questions. Does anyone have anyone that they want to ask? Or we know we've always.
Rochelle, this is Jason.
Please go ahead. Yeah, no, go ahead.
Rochelle, hi, this is Jason from the University of Kansas Health System. I have a question around, I think your slide where you had the Senate Bill 1988 pointed for Senator Moran, who had indicated, I think, 4 different things. One was parity, and the other one was geographic location changes. I've read the bill. I have a lot of questions around the geographic restrictions lifted. In your opinion, or in what you understand as the geographic restrictions being lifted, I read it 15 times trying to understand what exactly is being lifted. And my concern is when we say geographic restrictions, we know right now the geographic restrictions are designated by HCPCS designations.
Right.
And when we say we're just going to blanket lift them, is that how you read it? Because my concern is what is meant in the bill and what is stated and what you and I kind of just interpret may be different things. So here's an example. We say we remove the geographic restrictions, but that's not actually what it means. And what it means is that the patient no longer has a geographic restriction of going to a healthcare facility in a HCPCS designated area, but actually can be at home in a HCPCS designated area, meaning that a patient in Johnson County can in fact cannot see a physician at home, but a patient in Norton County can see a physician at home because A, geographically they aren't required to be at a healthcare facility, but B, the HCPCS regulations have not been lifted. Do you know if it's just carte blanche? The patient can be essentially anywhere in the state of Kansas. Well, I guess actually this is a federal, so just anywhere in the U.S. Or is it really just the patient doesn't have to now go to a healthcare facility, but still has to be considered in an underserved area for them to be seen?
Okay, so that's a great question. What I'll do, Jason, is I'll go back myself and look at the language in the proposed bill, because what I hear you saying from the language that you've read also strikes me as a question I often have when I'm reading these bills, where you and I know when we talk about the originating site, there's really 2 things, 2 restrictions there. And one is the rural health restriction, that the patient be in a rural area, and that's the HCPCS designation, and based on the last census and how they're designated as a rural area as that term is defined under HCPCS. The second piece of the originating site restriction is where the patient, the type of setting where the patient is located. Is it home? Right. Is it an eligible originating site? like have expanded access to critical access hospitals, a rural health clinic, a physician office, et cetera? Are they presenting to an eligible healthcare setting in a rural area? And so there's kind of two pieces of that.
Right.
What I've seen in some of the previous bills, and admittedly, when I saw yesterday that this bill was published and I got kind of the synopsis of what it would do, I haven't read the full language of it yet. And I'll do that, and I'll send out my thoughts on it. In other telehealth bills wanting to remove that geographic restriction, I see language that kind of confuses the two concepts and not realizing that there is a distinction. And the way that you're kind of describing what you've read, it sounds like that may be present in this bill as well.
Yeah, in fact, actually, I read the actual bill and I read the summary and the actual bill. And unfortunately, the actual bill literally is the summary. So the language is one and the same. So when you go into the actual bill and read it, it's a very lengthy bill, but unfortunately, the only part that addresses the geographic is essentially one sentence, which is also the one sentence I've seen in, I think, Becker's and IT News report and all that stuff. So I was hoping that maybe I missed something and maybe you caught it, because
that is so interesting. I will go back and read it and share my thoughts, because my understanding of the intent, when they say geographic restriction, in my mind, that means the rural area.
Yeah.
Because from our kind of billing and compliance perspective, there's a second piece to that on eligible originating sites, and that has a different meaning than geographic restrictions.
Right.
So that was my understanding in several of the bills. I thought the intent is that piece of it, getting rid of the rural requirement. Yeah. However, if that's the only thing we get rid of, then the patient, even in Johnson County, Wyandotte County, would still have to be physically situated at an eligible originating site, which would not be the patient's home, unless that second requirement is also modified.
Yeah, and that second requirement is not addressed in the bill. And so my concern is that we have good intent, but we don't solve our problem. And so actually, I'm working to try and see if I can get in front of our senator here in the state of Kansas to actually ask that question, if that was a mistake or if that was intentional.
Yeah, and Jason, I can go through and try to pull, if you were to search congressional telehealth bills, you're probably going to find 5 to 10 in the last year, with varying degrees of changing these flexibilities and specificity on those requirements. So while this one may only have language about geographic restrictions, there are a number of other bills that might address both, because I've also seen several summaries of bills that are addressing home as an eligible originating site, and something that we want to move towards as well.
Yeah.
So it's very possible, while this is the newest one, that doesn't mean it's kind of the hot one that's being considered. Sure. We may end up with another one of those bills moving forward that more clearly addresses both the geographic restriction of a rural area as well as an eligible originating site.
I think the reason why I'm so concerned about this one is it's 2 Democrats and 2 Republicans, which means there's bipartisan, and the other ones kind of are coming from separate camps, not a bipartisan. So I was thinking, well, this one actually might be the one that gets traction. That's kind of the one I'm concerned about.
Yeah, well, you know what, Jason, Jerry Moran, every time I drive home, I drive right past a sign that says Offices of Jerry Moran. So if you want to go meet with it, let me know. We'll go meet him together and kind of explain this distinction on originating sites and geographic restrictions.
Well, that's good to know. No, I appreciate your answer. Thank you so much.
Yeah, and I will go back and read it and share my thoughts with the group too.
Appreciate it. Thank you.
Well, I appreciate everyone today participating. I appreciate the good question. I used to be the director of primary care, and the only thing I would put in on the HPCS side is that's not really considered a geographic. That's a different type of designation, but I know that Rochelle will look closely at the bill. And the other thing is, of course, Senator Moran always has had excellent health staffers who I'm sure will help with the question and look at the question. And also, he's always been very open to input on what's good for the state of Kansas. So we will definitely provide everybody some answers to that. in the FAQ on our website related to billing, and make sure that everyone gets the information related to that, because this is an important bill with obviously some strong support in Kansas coming from Senator Moran. So I hope everyone has a good week. I appreciate you joining us for our June sessions. Christy, I believe this is the last June session. We'll pick up again in July. Is that correct? So hope to see everyone in July. And Christy, what is the next session? Just to let us know kind of what's coming up.
Yeah, our next session will be July 15th. I don't have the topic in front of me, but we will be sending out the flyer with the dates and the info and how to sign on all of those here in just a little bit.
All right, well, hope everyone has a great week and a good 4th, and we'll see you after the holiday. Have a great day.